Greetings, everyone. I'm Joyanne Courtney from NIH Office of Disease Prevention, and on behalf of the Planning Committee for this special theme plenary session entitled Advancing Gender Health Equity in the Context of Social Justice, we would like to welcome you to this session. I would like to take a few moments to acknowledge the Planning Committee. So if you are willing and able, please wave your hand or stand up so you can be recognized. Katrina Debnam, Associate Professor, University of Virginia School of Education and Human Development, SPR Board Member. Dion Gaudette Greer, Program Director, NIH, National Institute of Nursing Research. Carrie Green, Professor of Public Health at the University of Maryland and co-chair with Katrina on the SPR Early Career Prevention Science Training and Mentoring Program. And Rosalind King, NIH Office of Behavioral and Social Sciences Research. So thank you, committee. So more about this session. In many societies, including developed countries, achieving gender health equity is a significant public health challenge. Gender-based inequities are generated by differential opportunities in education and employment, discrimination, unequal power in relationships between different genders, law and policies that differentiate impact health by gender, social norms that dictate stereotypes, reproductive and caregiving roles by gender, and risk of physical, sexual, and emotional violence between genders. The intersectionality of gender membership with other statuses means that these inequities are exacerbated by racial, ethnic minority women, and gender minorities. Prevention science can achieve research to better understand gender-based health disparities and build an evidence base for interventions to foster gender health equity, particularly among members of multiple disadvantaged groups and across the developmental stages of life. The topics highlighted for this discussion include: 1, interactions of biology and social determinants of health that may influence gender health equity; 2, health syndemics of substance or alcohol abuse, violence, HIV/AIDS, mental health, or obesity; 3, strategies to prevent and alleviate the health impacts health impacts of gender-based public policies; and 4, applying an intersectionality framework to advance health equity prevention research among women, particularly those marginalized by race, ethnicity, sexual orientation, or gender expression. So I'm really pleased to introduce our speakers for today. I'll introduce all three, and then they will give their presentation and talk. Each person, we can have a moment for questions after each person, and then we'll have a panel discussion at the end where you can address questions to everyone. So Katherine Theall is a professor at Tulane University School of Public Health and Tropical Medicine. She is a social epidemiologist and actively involved in interventions and policies aimed at altering environments for better health in vulnerable populations. The title for our presentation today is Getting Under the Skin: The Role of Social and Physical Context in the Shaping Gender Health Inequities. John R. Blosnich is an associate professor and director of the Center for LGBTQ plus health equity at USC School of Social Work. His primary area of expertise is disparities in suicide risk and prevention among lesbian, gay, bisexual, and transgendered individuals, with a special emphasis on social determinants of health. John's presentation is Health and Social Inequities: Turning Patient-Centered Medical Homes into House of Cards for Gender Minorities. Goleen Samari is an assistant professor of population and family health at Columbia Mailman School of Public Health. She is a population health demographer and examines how racism, gender inequities, and migration-based inequities shape reproductive and population health both domestically and globally, with a particular focus on communities in or from the Middle East and North Africa. The title of her presentation today is Structural Isms in Gender Health Equity, Measurement and Implications in the U.S. and globally. I'll turn the podium over to Kat. Thank you.
Good morning, everyone. Thanks, Joanne, for the introduction. As she mentioned, I will be discussing the role of physical and social context in stress embodiment. And this is my actually second time at SPR, but I do a lot of prevention work, which I actually won't be discussing this morning, but we'll be talking about some of that tomorrow. So I look forward to coming back and being more engaged in SPR if possible. First, though, if I can advance the slides. There we go. I want to acknowledge and thank all of my amazing collaborators, co-authors, community partners, funders, and really the staff and students, and especially the participants and families in some of the studies I'll be talking about today. I want to especially thank Doctors Stacy Drury and Bertie Shirtcliffe, who have allowed me as a lowly social epidemiologist to really connect context to biologic stress, which has only increased the questions we ask and what we can do in an interdisciplinary partnership. I want to also acknowledge my positionality as a white, heterosexual, cisgendered woman with limited direct experiences of some of the context I'm going to talk about and study, but I do approach my work and research with a community partnered approach, centering the voices of and lived experiences of those in these contexts. So this morning, I'd like to first, I'll talk about three main areas. One, a little brief intro on stress embodiment, some theories, review of the stress process, and then measures of biologic stress and how we can actually capture that from a research perspective. Secondly, I'll provide a few empirical examples from our own work, particularly among youth. And finally, I want to discuss a few implications for prevention, since this is SPR, including the need to move further upstream and away from a single axis lens, which I think will set Goleen up really well. So in terms of theories and frameworks for stress embodiment, and by embodiment, I just mean the way we literally biologically embody the social and physical world in which we live. There's lots of theories and lots of frameworks. This is not an exhaustive list by any means, but some that are commonly employed. We have Alyssa Eppel's transdisciplinary model of stress, which I'll show you in a bit. We have Alicia Francis's embodied theory of stress, which really centers experiences, prior experiences, coping, and situations in that stress process. We have the risk regulator model, which many of you may be familiar with from Glass and McCarthy, and it centers behavior at the core, but it's really influenced by above water contextual factors as well as things below the water biologically, which again, a direct link from environment to underwater factors, but also indirectly through behavior. And another, commonly employed, very complex theory is ecosocial theory by Nancy Krieger, which I'll also show you, which is really a theory of how racism gets under the skin to be embodied. And, there are also theories for specific populations. I've listed a few here. There's Karina Walters and Jane Simone's Indigenous Stress Coping Theory, which really centers historical trauma at the core of stress, and then includes historic buffers and cultural buffers to help mitigate that process. There's the weathering hypothesis by Arlene Geronimus, which again, many of you may be familiar with, which is really focused on the wear and tear of physiologic systems among Black women in particular, given hardships and social situations. And finally, there's the minority stress theory from Virginia Brooks and adapted by Ian Mayer, which focuses on the impact of stigma and prejudice and really that internalization of societal stigma from the stress process. Okay, so just a quick visual. I won't go into detail on all of this, but just so you have a picture of the transdisciplinary model. This includes, I just want to point out a few things, key exposures across, context, individual and environmental, historical situations, historic stress, cumulative current stress, as well as protective factors, which is really important. And then it also includes multiple processes in addition to, psychological and physiological processes, the model includes habituation and some of these behaviors that really do play a role when we think biologically about how stress is impacted. And then finally, it includes time scales as well. So acute stressors, daily stressors, life events, chronic stressors. So a pretty comprehensive model. Eco-social theory, which is extremely complex yet comprehensive. I won't go into detail, but I do want to point out, in the model and the theory here, Krieger notes that there are issues of accountability and agency at every level of influence, which is really important when we think of how, or the magnitude of health inequities, and then also how we monitor, address, and analyze inequities. So a real key piece to her model. So just a few primers. In terms of biologic stress, what is biologic stress? What do we mean by that? And, the traditional definition of stress comes from Lazarus and Folkman's stress and coping theory, in that a stress occurs when a person perceives a stressor to be greater than their ability to really meet the demands or adapt or alter that stressor. And so that's referred to as a maladaptive stress response. And it's really, the coupling of wear and tear physiologically and repeated hits over time, coupled with that maladaptive response that can lead to allostatic load and kind of this biologic stress. And, in the most simple terms, we can think of stress biologically in three ways. We have positive stress, which is good. We all need, brief increases in heart rate, mild elevations in our stress hormones. We can have tolerable stress, which is serious and temporary, but buffered by supportive relationships or some type of buffer. And then we can have toxic stress, which is really prolonged activation of the stress response systems in the absence of supportive relationships. And, as you saw in some of the models and frameworks, we really can't think in linear terms about the production of stress and biologic stress. And when it comes to toxic stress, there are a lot of stressors that, like living in poverty, really seem to have no clear end in sight. And so really requires that chronic adaptation. And of course, toxic stress is, not merely a flesh wound, can really create lifelong lasting scars that have great implications for health and health inequity. So a quick review of the stress response. Again, I'm an epidemiologist, so disclaimer there, but we have stressors, again, that activate the HPA axis, which increase cortisol production, our main stress hormone. And cortisol intracellularly then increases glucocorticoid receptors, the whole glutathione dysregulation and adaptation process that increases oxidative stress or reactive oxygen species. These in turn can increase inflammation, mitochondrial dysfunction, all of which can impact telomeres, which are shown here as, I don't know if you can see the orange on the tips of these little X's, which are our chromosomes in the cell. But telomeres are nucleoprotein complexes at the tips of the chromosome, and they protect the chromosome so that the cell can form its function. And they're extremely sensitive. They shorten with every cell cycle replication. So they're a biologic marker of aging, but they're, artificially shortened and accelerated in shortening by an environmental stress. And that, can include anything, but a lot of, both social and environmental stressors. So it's an extremely sensitive marker, but a great potential one for that cumulative biologic stress. And, measuring biologic stress is very complex and complicated. There are various forms of stress, right? We have social stressors, psychological, biologic. It's a big mix. And there's also, when we think of biologic stress, varying patterns, both acute and chronic. Some of the acute patterns I have below in Jester's allostatic states example, but there's differences in how we respond and adapt to stress. And those patterns biologically can play a big role in health. And then there's still a lot we don't know. And there's also patterns based on sex and gender. Men and women experience stress differently physiologically and biologically. For example, women on average have longer telomeres than men. There's not a lot of literature from a gender perspective, but those that are out do suggest also that sexual and gender minoritized individuals have greater biologic stress as well as psychological stress. So there's a lot of different patterns. There are also few agreed upon measures when we think about how to capture this biologically. I listed some of the common ones here. The one is allostatic load. A lot of folks in public health have used this marker, and it's really, again, a cumulative marker, ideally measured with biomarkers from 3 biologic systems or organ systems. So neurologic, endocrine, cardiovascular, and immune, which can be really hard to do, but a cumulative marker. We also have cortisol as a primary hormonal marker that a lot of folks examine, and many people, probably more commonly in public health, look at chronic cortisol or diurnal cortisol, that kind of pattern over the day, and maybe the cortisol awakening response. There's also acute patterns, but that is really complicated to collect in a laboratory setting, for many of us at a population level. Telomere length is a great marker, just described. Again, fairly easy to capture through blood, through saliva, through buccal swabs. It's really a great marker that can be scaled up. And I think a lot of our studies nationally are definitely doing that or have done that already. There's cardiovascular markers. We have, of course, heart rate. I included one called RSA, respiratory sinus arrhythmia, which I think is a great marker of emotion regulation. Very tough to collect, again, in a laboratory setting, but higher RSA is indicative of greater emotion regulation, which is important from a stress angle. And then, of course, immune markers, inflammatory markers, such as C-reactive protein, which is a really common one. All right. Excuse me. So a few empirical examples where a lot of my work has really focused on youth and younger children to really, examine the impact of early stress, early context, and how that might be embodied. And so in one example shown here, we looked at in Haynes, the Nutrition, Health, and Examination Survey with the 1999 to 2006 continuous surveys. And we looked at youth ages 12 to 20 years to see if cumulative neighborhood risk in their residential neighborhood impacted allostatic load. And so we had about 10,000 youth coming from about 2,400 census tracts, which was our definition of neighborhood and is my definition of neighborhood in most studies I'll present. And then cumulative stress in the neighborhood included various things, levels of poverty, crime, violence, food availability or, non-availability, alcohol availability, walkability, green space, you name it. And what we found is really a dose response pattern shown in both crude and adjusted models, but you can see, as the level of cumulative risk in the neighborhood increased, the likelihood of having high allostatic load also increased, with youth living in extremely high compared to low neighborhoods being about 70% more likely to have high allostatic load. And that's controlling for a lot of individual factors, family household factors, as well as some other neighborhood conditions. And while not shown here, we also saw this dose response to be greater for girls than boys in the sample. And, we've looked at this similarly in other contexts internationally. I just wanted to give you a picture of that. This is among a sample from the Jamaica Health and Lifestyle Survey in 2008, which is a large population-based cross-sectional survey with individuals 15 to 74 years of age. And here we looked at select neighborhood risk conditions and their impact on allostatic load. Although we didn't call it allostatic load, since we didn't have markers from 3 biologic systems, we called it cumulative biologic risk. And what we found is women on average had higher cumulative biologic risk scores than men across all age groups. And then women living in more disordered neighborhoods had a greater likelihood of high allostatic load or CBR, and then those living in neighborhoods with greater recreational space had a lower levels of CBR. So a few more examples, I promise, just 2 more. Wanted to give you a sense of some work we've done with telomere length, and a lot of that work has been more hyper-local in New Orleans, Louisiana. And so this example comes from a cross-sectional study of youth ages 5 to 15 years. And we were interested in this one paper in looking at family context and really cumulative family instability and the role that it might play in stress embodiment And that cumulative family instability included witnessing family violence, having a parent incarcerated, and then also experiencing a family suicide. And what we found was significantly shorter telomere length on average. Oops. Are we way far away? We found significantly shorter telomere length on average for children with higher exposure to cumulative family context, and witnessing family violence played a particularly potent impact, and again, stronger for girls than boys. And a similar hyperlocal study, although in this case, a longitudinal cohort of mothers and infants recruited during pregnancy at any trimester. And this again is in New Orleans. We've examined a lot of different contexts and how they may shape the biologic trajectory and maybe be sort of transgenerationally transmitted. And in this example, we looked at hyperpolicing in neighborhoods of the mothers during pregnancy and how that potential marker of racism may play out for biologic trajectory of the infants. And we did find a significant decline in telomere length for girls, particularly female infants born in neighborhoods with high rates of stop and frisk compared to boys. But then on average, irrespective of sex, these infants born in these conditions had longer telomere length than those born in sort of lower risk environments from a neighborhood angle. And that might seem counterintuitive, but longer initial telomere length is actually linked to accelerated decline over time and over the life course. So makes some sense in that respect. All right. So what does this mean for prevention? As a observational and interventionalist from an epidemiologic perspective, I think, a lot of our work and my work in this space has really pushed the needle to, again, understand the role of biologic stress, but to point to the fact that we can change conditions. They get under the skin early, so we can't blame behavior on a lot of this biologic stress embodiment. And so how do we move a little further to change those contexts? And, I think we definitely need more curve shifting, as shown in Rose's seminal work here with a population approach. But I do think we still need the risk reduction angles, and it's really a both and. We know population shifting is a long game, and so we've got to keep both going for sure. And a lot of studies, interventions have shown that the biologic stress trajectory can change with interventions. And I have a few reviews here for cortisol, telomere length, and allostatic load, all showing a pretty consistent positive impact on change in biologic stress. These mostly, however, are from individual level interventions, but nonetheless are pretty promising. And despite the need for individual interventions, which we still do need, we all know we need to really move further upstream, beginning to address more of the forms of oppression, the social hierarchies that really shape health and health inequities, gender or otherwise. And, if we don't, we're just really putting Band-Aids on a lot of the problems, right? And so I think that's key. I think what's also key is thinking about the intersections of these forms of oppression and how they really play a role in health and health equity, and what we might be missing by not considering some of those intersections. So for example, in a lot of Geronimus's work for Black women who live at the intersection of, sexism and racism and those different experiences, or a Black trans individual versus a white trans individual living at the intersections of gender binaryism and racism, and those differences that we need to better understand, but also address in our interventions. And we see intersectional invisibility play out, of course, scientifically, but of course in popular culture too, right? The Say Her Name campaign to draw awareness to the fact that Black and Latina women are killed by the police too, right? Often not talked about. So definitely need to move further upstream. I offered a few prevention approaches, and again, none of these really address root causes, but I think they can continue to get us a little further along in this game. And I think we can continue to address the multi-level determinants, right? Housing insecurity, food insecurity, employment, neighborhood conditions, which is some of what my work focuses on. I think secondly, we can sensitize systems, educate organizations and institutions that help to perpetuate some of these inequities, healthcare settings, law enforcement, police settings, which, those interventions are growing as well. We can also keep targeting interventions. I think moving upstream though, as much as we can. And when we can't, really, for individual level interventions, making sure the lives and the context of these individuals are taken into account, even at that level. And I think improving coping and social support is really key when we kind of think about the buffers for biologic stress. And then finally, and I think we'll talk about some of this in tomorrow's plenary, we as researchers can, use our research and be involved in the activism, in the social organizing and study social organizing, education, allyship, and action to really promote the population change and the curve shifting that we need on a lot of these levels. So in summary, there are many theories of stress embodiment. There are many ways to measure stress embodiment, all of which are important as we understand inequities, both gender and other forms. But I offer three kind of buckets from a future direction angle. And one is in research and evaluation. Of course, we need, like I said, to expand our prevention efforts to move away from this single axis lens. But we also need better data, absolutely, right? If we don't have the data, we can't understand, we can't monitor. As Krieger notes, if you don't know, you can't act. If you don't know, you can't act, something like that. Anyway, data is important. Also, I think focusing on strength and assets, a lot of our work does try to mitigate exposures, but continuing to focus on what's going right and well within communities and individuals that we can capitalize on. From a training and education angle, of course, we need to expand training, more training on methodologies and methods that can allow us to move further upstream, to ask the right questions, to test the right interventions and hypotheses, and then also strengthening cross-collaborative training. Gender inequities, racial inequities, no inequity is going to be solved by one discipline. And so it's really important that we continue to do that work. From an outreach and translation angle, we all know we need to increase dissemination of our work beyond scientific settings, which again, still need to do more of for sure, and turn our research into action. But I do think we can also partner and lift up community partners and voices and those doing amazing work on the ground. There are folks with the lived experience doing wonderful prevention and intervention work that never see the light of day. And so how do we really do better in our partnerships? And there are mechanisms now, both private and NIH actually has one, the Compass Initiative, which is trying to allow much more of this. And I think we need it if we're going to move the needle. So thank you all for your time. And I think we'll take a few questions. Questions? It's hard to see with the glare, but. Okay.
Yes.
Yeah.
Did you use the mic?
Yeah, thanks.
Did you use the
Great question. I can repeat that. She asked if I had a plausible explanation for the sex differences we saw in a lot of the studies we observed. I think a lot of the work is pointing to hormonal differences in many cases, particularly estrogen and its role in sort of a more protective response. But there's a lot of hypotheses on why, for sure. But my guess is probably more hormonal in nature. Telomerase as well. Telomerase is an enzyme which lengthens telomeres. So for that particular biologic marker, there are differences in kind of how telomerase is expressed as well. And psychologically, I think, how we internalize the stressor might differ too. So great question. Any other questions? Nope. All right. Well, thanks. I'll turn it over to John.
Awesome. Thanks. Morning, everybody. So, hi. I do have a couple disclosures to make, and just some depiction of of my background. I'm from Appalachia, first gen person who never thought I would go to college and then went to like all of the college. But most of the work, some of the work I'll talk about that I've done really happened while I was working with the Department of Veterans Affairs before I got to USC. My background is in public health. I'm not a social worker, even though I'm in a school of social work. They mostly don't hold that against me. So I thought it would start with something maybe really easy. That's usually a safe bet early in the morning, and just how pervasive gender is in our society, right? There's a headline, but you can see that, this example from California, gender is actually an implicated sort of attributable cause to a forest fire in California because it was a gender reveal party kind of gone awry. Down to this, this middle snippet of a newspaper clipping for folks in the back who can't maybe not read it. Women paid less than men in same jobs, study shows. So there's a headline. But what you might not be able to read is that this was published May 25th of 1939. So it may as just as well have been written yesterday, right? Down to the last bit, which is evidence of, discrimination being actually enshrined in law in the United States right now based on a person's gender identity. And so what do we mean when we talk about gender identity? It's typically thought of in terms of three different components, right? So one is sex assigned at birth, which is typically made by a medical professional on visual, recognition of external genitals of a newborn, right? And then that becomes sort of official when it's recorded on the birth certificate. And the next thing is someone's gender expression. So how someone chooses to show their gender to the world. And so this can be through hair, through makeup, typically through clothing. And then finally, these things culminate into a person's actual identity. So the way that they think about themselves, the way they actually define themselves. And surprise, everyone look under your chairs because you all have a gender identity, right? This is not a construct that's only meant for trans people. Everybody has a gender identity. And this will become, hopefully, I'll underscore the emphasis of this when I get to the data collection part of this. So, probably one of the most common terms that we hear, we see, we read, we think about when we hear the word gender identity is transgender. And that's really an umbrella term. And so you can see here, these are examples from the US Transgender Survey or the USTS. It currently is the largest sample of transgender nonconforming group of people that we currently have. I think they're working on the maybe the data collection or even the analysis of the next wave of that survey. But this is almost 28,000 people who identify as trans or gender nonconforming. And interestingly enough, and this might give the EPI people in the room a little bit of anxiety, on the survey, they were like, check all that apply for how you would describe your gender identity. If none of the terms here describe you, please tell us what we're missing. And you can see here that there are a lot of ways that people can describe their gender identities when we give them the space and the opportunity to do so. But one of the most important points of this is that a person's gender identity is not predicated on medical therapeutics at all. Their gender identity is their own. Now, we use the abbreviation LGBT very frequently. And the problem with this is that it mixes together notions of sexual orientation and gender identity. So the LGB part and the T part. And this may seem very evident to a lot of folks who work in this space of sexual and gender minority research. But in a separate project, I do training death investigators to gather sexual orientation and gender identity information when they go out to do investigations of violent deaths. The conflation of sexual orientation and gender identity is very, very common. And some of that is back to this moniker of putting them together as LGBT. So I just highlight here an example. These are data from the Behavior Risk Factor Surveillance System survey from CDC. And you can see that, when you look at how transgender and cisgender people describe their sexual orientation, there's a sizable portion of people who identify as transgender who describe their sexual orientation or sexual identity as heterosexual. Now, that's not to negate that, other sexual identities are much more prevalent in this group, but heterosexual is a viable way for a trans person to describe their sexual orientation. And just because we lump things together into LGBT, it does not mean all gay people are trans and all trans people are gay. And this is something I have to hit home, and something I took for granted because I work in this space so much. But for folks who don't work in this space that often, the confusion and the conflation is very real. And so now that we have terms, constructs, down, we can turn to the issue of health disparities, which are numerous for trans and gender diverse people. I just highlighted a few here around. There's so many more around physical health, mental health, social adversities. Some of this is work that we've done in the VA system. Others come from the best that we can kind of pull together from convenience-based samples of folks. Because when we get to the data part, you'll see that we kind of do the best that we can with the data that we have, but the data that we have aren't that great. So the point is, even with not so great data, these disparities still can shine through. We can still find them here. And so when we think about these health disparities, I think it's really important to frame them as well. So in the terms of, or in the context of health services research, so Amy Kilborn and colleagues a while ago put forward this sort of 3-generational model to think about health disparities. So you got to first detect that there is a problem. You got to then work to kind of understand it, and then together move on to how you address that, right? You have to, with that information, you can actually form interventions to think about interrupting the disparities that you're seeing. Now, Stephen Thomas and colleagues came along and introduced a 4th generation of research, more from a public health standpoint, arguing for critical praxis. So it's not enough to have these first 3 steps. They've really got to be grounded in thinking about the patterns and the history of oppression that give rise to these disparities in the first place. And at the time, this was sort of a revolutionary point to emphasize for health disparities research, but it's so critical in how it turns the lens away from the individual, right? Because a lot of times all we have is individual characteristics and how they're associated with a negative outcome, and we don't have the actual data on the driver of it. So the person's identity becomes the thing that we see, the thing that's in our data set, the thing that makes it onto table 2, table 3 in our papers, and not the things that are lurking behind it, the things that are the reason why a group or an identity is experiencing the things that we're seeing in the data. And so speaking of revolutionary things, I just want to take a moment, if you all could, think about this quote from Laverne Cox. So she's an actress. She was on Orange is the New Black, if anyone remembers that show from a while ago, back when Netflix didn't care if someone else had your password. But, thinking about her quote and picking out a word in there that really, speaks to you or stands out to you. Maybe it's revolutionary, maybe it's exist. For me, it's the word choose. That she points out people choose to be visible. And for me, thinking about that, to choose something means that you've weighed your options. And what are your options, right? And so thinking about marginalized populations, the options could be, well, I guess my option is to not be visible, right? My option is to maybe, do I believe that people think that I shouldn't exist? And those are horrible options to weigh before choosing a path to be visible, which is also laden with a lot of hazards and danger, especially now, historically too. But it's not a choice that a lot of us thought about this morning when we came here. It was, do I have enough time to get coffee? Am I going to wear that shirt? Do I like how these shoes look? But we didn't weigh a choice about, should I even exist today? Right? Do I choose to be visible to tell people who I am today? We didn't even think, probably a lot of people in the room did not think about that. And it sort of grounds this idea of self, right? It all comes back to the person and individual choice. But for me, as a health equity scholar, the focus on self is important, but it also has this hazard of us, kind of tunnel vision on this, on a level that is not the whole story. And so these two quotes here are pulled out from previous studies. You know, to me, I think they point out that this focusing on self, although is important, like I said, it's the thing that we're measuring, but it's the thing that we're seeing, but it's not the thing that maybe we should be measuring. It's not the thing that's giving rise to why a group or why, a marginalized population is experiencing the disparities that they're experiencing. And that it's really about the agents of discrimination and the agents of oppression that we're not seeing and that we're not measuring, because they're very, very clever. Oppression is incredibly clever, especially now. Here, these participants are explaining how it's hard to describe. They don't know why this is happening to them, but it's happening to them. And that is a burden that's put on the individual, right? To describe what's happening to them, and not about researchers trying to interrogate the systems, right? These are the sentinels, these are the canaries in the coal mine, but who are the agents that are driving that behind that? Those are often things that we don't think about. We don't turn our tools to measuring that part of it, right? And so this kind of lack of evidence around sort of these agents of discrimination, agents of oppression, are paired with this overall lack of data on trans people, period. And it is very difficult to carry forward your work if you can't find the population that you need to work with, in our data systems especially. And, so a very common phrase is no data, no problem, right? As you can see here, even in health systems that are now moving towards trying to include gender identity data in their EHR record, their electronic health record data, it is very spotty, very missing. And just take a minute to think about if this was race data, if this was ethnicity data. How would we ever discover if there are any differences if we couldn't find the group and understand what's going on with that group? And so that's really, from my perspective, where we're sitting with trans people, especially within the arena of healthcare data. It's very hard to find people. And so what is a researcher to do? So in this example, we in the VA, we defaulted to using gender identity disorder. So GID is no longer a diagnosis in the DSM, the Diagnostic and Statistical Manual. It's been replaced with gender dysphoria. Now in the VA, coding is based on ICD, and an ICD, GID is still there. So without any information about a person's self-identified gender identity in VA, we took folks who had this code and we looked to see, well, are there any words or phrases in there? And we did this a while ago, it's like 2016, 2017. Is there anything that would corroborate why someone would use this code in our system, right? And so what we found of the folks that we found, almost 90% of them had a word or a phrase that was pretty explicitly corroborating the use of this code. So making us think that this might be a fraught but workable proxy for trying to find people in the data. So what would you do after you found this? You think, well, I need to test it in a group of folks who don't have this code, right? And so when we did this in folks who don't have this code, very few hits, but there were some for sure. And some of these, maybe like we had 246 who had at least one of these terms in there as well. So we had to hand review those charts to figure out what was going on here. And some of them, not a whole lot of them, but some of them were the exact same phrases we saw for the group with the code. But many of them were the patient, mentioning something that, a clinician had taken down, and it was about somebody else, maybe someone they knew, someone in their family. It wasn't about the patient themselves. But this is a lot of what I call data gymnastics. And again, imagine if you were trying to do this to try to figure out someone's race, a patient's race in the records, and just how fraught that would be. But when you can find a group of people, you can do some pretty amazing things. We don't know the leading causes of death for trans people in the United States. We have a slew of information telling us that the risks for a lot of things that threaten people's well-being are much higher in this group, but we don't know how they die. which is very important. I do a lot of study of mortality. I'm a strong believer the best way to keep people alive is to learn how people die. Pretty grim work. I swear I'm the life of the party though. But when we were able to look at the leading causes of death for trans veterans in the VHA versus who we deem sort of non-trans or cisgender veterans in the VHA, you can see heart disease, cancer, 1 and 2, it aligns on this graph. The line with the X is the leading causes of death for the United States in general. The red circle are cisgender veterans, the blue square is transgender veterans. I want to call your attention to the last part, which is suicide, typically the 10th leading cause of death. It was the 10th leading cause of death for everyone in the United States, 10th leading cause of death for cisgender veterans. It was the 4th leading cause of death for transgender veterans in the VHA. So we can get outcomes on folks, but we can also find out about how systems are working. So I mentioned a little bit earlier, showed earlier, that housing instability is a huge problem facing trans and gender diverse populations. But heartening evidence from VA suggests we have in the VHA, there's a lot of permanent supportive housing. And you would hope, right, that if there's a disparity in risk, you're going to see the exact same disparity when you look at the solution. The group experiencing the problem the most should also be the population getting the solution the most. If there's no difference, you're in trouble. And if it's in the opposite way, you're even more trouble. But what we found was that some permanent supportive housing programs in VHA are reaching trans veterans at a disproportionately higher rate than they are for cisgender veterans experiencing housing instability, which is how it should be, because trans veterans are more likely to be experiencing housing instability. So when you have the population you can find, you can actually look at how, systems are working for folks. Now, that's to say all these gymnastics don't have landings of perfect tens. So when we looked at the consonants between the denotion of sex, so either in the EHR from VA, and then we looked at, this is among people who had died. So we were able to get their death certificate. So what was their sex marked in the death certificate? So again here, these are people without GID codes in the VA, and they are 100% consonant. The sex marked on their death certificate aligned with the evidence we found in the electronic health record. But then when you look at decedents who had a GID code, it becomes less clear. And we don't know what this means. Which record was more accurate? Or it was accurate at all. We have no idea. So all that to say that even though we can find folks and we can do some of this work, there are still a lot of questions around this, and we just need the ability for people to answer their gender identity and not have to go through these hoops. I didn't know it was going to be like an American Ninja Warrior course to end up, doing this kind of work. But healthcare is moving more towards social determinants for sure. You can see here, starting with Paula Braveman's review in 2011 that showed, it was sort of a heartening look on this, that it's increasing. I took away from this graph that the U.S. is, in the corner, the U.S. is really behind the rest of the world in terms of conceptualizing social determinants as a driver of health. This is probably looks much different, thankfully, now, because we see that there's been progress in how we think about this, how we embed it into our research, and how we embed it into our healthcare system. But even though the healthcare system is leaning into social determinants, will they actually lean into advocacy? And so this example here is from few years ago, when the NRA tweeted about doctors staying in their lane, and this was in response to a position paper that's published in the Annals of Internal Medicine about gun violence and injuries and deaths due to firearms in the United States. And what this resulted in was a huge wave of activism by individual physicians and medical professionals who basically said, this is my lane. I don't know, I'm not aware of any health systems that they themselves sort of, might have issued the same sort of tweet from a more official system, organization-based perspective. But here we see really a calling of folks coming forward to really engage in some form of activism, right? The smallest form of activism, but standing up. And we need that now more than ever for trans folks. So this map shows there are states that are passing bans on evidence-based care for trans youth. I accessed it on May 24th, but it's even out of date, right? Because Texas is not the right color, because Texas had just passed their ban on the 17th. So this is very quickly evolving, but really still needing that call for activism, because these are types of things that are threatening the well-being of trans people across the United States. And so I just want to sum up here. We know that patient-centered medical homes, the medical home models, that they work, but the issue is they may not work for everybody, and they may not be working for marginalized folks, for folks who have been marginalized for a long time. That includes, trans populations. And that we really have to think about, keep doing our research, but we have to think about explaining inequities in the social, political, and historical context to give rise to them, and that they're not placed on the individual. We have to create and facilitate ways for people to be visible in data, and we have to create safe clinical environments where people feel that they can actually, share this information with a professional. And as much as healthcare is leaning into this, and if they want to get into the game of social determinants, we need them to play to the buzzer. In that, they're learning. I think that coming from a biomedical model where it's diagnose, prescribe, diagnose, treat, social determinants, they're not fixed with medication. They're fixed with advocacy. And that's not something that a lot of medical professionals are trained in. So I think that there's a lot in the room for folks who work, social scientists, advocates, about how we can partner and actually bolster this model so it works for trans health. Thanks. I guess are we running good on time, or? Yeah. Okay, if anyone has questions, or we can keep moving, it's up to y'all. Hey. We'll keep moving. Yeah, right. Yeah. We'll keep moving. Thanks.
Okay, so I'm gonna follow that up by talking about measurement and implications of structural oppression. So small task. But to follow John's lead, I'm Goleen Samari, and I too did not expect to go through this much schooling. I wanted to be a pastry chef. But then my family is an immigrant Middle Eastern Muslim family. And when you tell your parents you want to be a pastry chef, they beg you to go to college. So here we are. I think it's important to start with some definitions. John did a really nice job of walking us through the gender related definitions. I want to emphasize structural determinants as opposed to social determinants, and structural determinants really being the governing processes, economic and social policies that can affect everything from sick leave to housing to education, which are really the intermediary steps to unequal distribution of power and prestige. I think it's important to really think about what does gender equality mean, which is the equal rights, responsibilities, and opportunities of women and men and girls and boys. And gender equality in health to me means that women and men are on an equal footing to fully exercise their rights and potential to be healthy and contribute to health development and benefits from outcomes. Achieving gender equality really means to concrete measures that eliminate gender-based inequities. Intersectionality is really important to frame in this discussion because in measurement of structural oppression, we're increasingly moving towards intersectional measures of structural oppression to reflect the lived experiences of people. So interlocking and intersecting forms of identity and their relationships to power. In the title of the talk, I mentioned isms. So what are isms? Isms are a connected system of ideas and beliefs and practices conceived by people with purpose in mind. So we often hear about them in like religious or philosophical or political dimensions, but in 2004, the Oxford English Dictionary revised the definition to include this aspect of sort of oppression or forming nouns with the sense of belief in the superiority of one over another, such as racism, sexism, ableism. And it includes this discrimination or prejudice against something on the basis of things like ageism, bodyism, heightism, sizeism, weightism. So I think that's important to think about as we move through this talk, which I'm going to give you some examples from my own work that really, how can we measure these concepts? What does it mean? My work largely focuses on the experiences of cisgender women. I think it's important to state that up front. So what is my approach to this realm? So structural factors and measures, or structural oppressors and their measures. So conceptually, I really focus on the climate or the socio-political environment. I'm really coming at this work from an equity lens. And oftentimes we look at this work through the lens of discriminatory or restrictive environments, but it's also increasingly important, particularly from a prevention standpoint, to think about what does inclusion look like and what does an inclusionary environment look like. Methodology can include a range of things. There's mixed methods approaches, qualitative research approaches, because we ultimately need to hear from the people about how they are experiencing these systems and environments. Lots of quasi-experimental and causal inference related approaches to look at the associations between these structural isms and outcomes. Levels of exposure can vary: global, national, state, local. What sort of dimension, geographic dimension of the sociopolitical environment has an impact or can make a change? Tools that are sort of used to construct these measures include policies, court cases, governance systems, social media. And then again, intersectionality is really important to think about across not just the concepts, but the levels. So first, I want to draw your attention to some work on structural sexism. And I use the term structural sexism to refer to the systematic gender inequality in power and resources that manifest in a given gender system. And I operate that it's really observed at multiple levels, so individual, interpersonal, and macro. And then in this case, we created a measure for 2018 for state level structural sexism based on a structural sexism measure that was conceptualized by Patricia Homan. And you see how it has a variety of economic, political, cultural, and physical reproductive dimensions, and draws on ratios of men's to women's labor force participation, things like percent of legislature seats, and policies to create a measure. And we were really interested in looking at the relationship between structural sexism and a term that's referred to as obstetric violence, so excessive sort of medical intervention in the obstetric space. And so this is the map of structural sexism in the US states and DC in 2018. With the higher, you can see that the red and moving towards red is more structural sexism at the state level. Structural sexism is highest in the historically sort of religious mountain states, so states like Utah and Wyoming, and the South, so Oklahoma, Arkansas, Mississippi, Kentucky, Alabama, and West Virginia. And when we looked at the relationship between structural sexism and obstetric violence, and for the purposes of this work, looking at C-section rates, we basically saw that for every point increase in structural sexism score of a pregnant person's state, they are 19% more likely to receive a C-section, controlling for a range of things. And in a strange twist of irony, this was published the same week I received an emergency C-section, so I don't know how much more C-section research I will be conducting in the future. Maybe I need a little space from it for a bit. Moving from structural sexism to a term I refer to as structural xenophobia. I think Structural xenophobia, it's also important to define because it has structural racism and systemic racism and anti-immigrant sentiment really at the core. And this type of measure that draws on these different sorts of discriminatory systems really requires you to think about structural intersectionality and what that experience is like for immigrants that are experiencing these different kinds of oppression. One way of sort of creating a measure of structural xenophobia is to think about immigration policy, right? And the US immigration system really shapes and is shaped by structural racism. And what do I mean by that? It's like if we look at historic immigration policy and acts like the Chinese Exclusionary Acts of the late 19th century or the Immigration Act of 1924, or recently the Muslim ban of 2017, you see that how these policies really reinforce the mechanisms of structural racism. And then there's also social and policy responses to immigrants that sort of further perpetuate this system. I'm going to focus briefly on the Muslim ban in 2017 because I think it's a good example of how you can leverage a federal policy that really shifted the socio-political environment to capture this dimension of structural oppression. So in 2017, part of the first acts of the Trump administration were to sign an executive order banning Muslims from several Muslim majority countries from entry into the United States. And so the research question for this work really was the 2017 Muslim ban, specifically the January 27th executive order, associated with preterm birth among women from those residing in the United States. And preterm birth is often used as a marker, an early indicator of the impacts of structural stress and oppression. It shows up in these sort of social and policy impacts really show up in preterm birth a lot. So our hypothesis was that the Muslim ban was associated with greater than expected levels of preterm birth among gestations exposed in utero to that policy. And this shows the results. And so it shows the observed and expected lines odds of preterm birth among women from countries born in countries affected by the ban. And as you can see, there's birth cohorts in the outlying sequence, which basically shows an elevated, unexpected high values of infants born in September 2017 with preterm birth, persisting through the cohort born in August 2018. So the findings show a 6.8% increase in preterm birth that can be attributed to the Muslim ban. And that's a period that began approximately 8 months after the executive order was enacted. And so thinking about Kat's presentation and the biological manifestation of stress, and this is a first trimester exposure. And so there was something in the first trimester exposure because of the shock of this policy that was associated with a 6.8% increase in preterm birth. And so these structural systems, sometimes it's one policy that can create a measure of structural oppression or an ism. Sometimes it's more than one policy and it's a collection of policies, but it's really about the socio-political environment having an impact on health and health outcomes. And this question of sort of structural xenophobia and anti-immigrant policies and rhetorics being associated with poor health outcomes has really gained significance as these types of policies have remained central to US immigration policy and the overall global geopolitical landscape. So because of this, I created a measure called the Immigration Policy Climate Index. And this measure is intended to be inclusive to all immigrant groups. It's intended to really center public health research focused on immigration policies. It covers 2009 to 2019. It's theoretically based, so 14 policies were included across 5 domains that were really created by Steve Wallace and colleagues. And the domains include public health and welfare benefits. There's 5 policies from that domain, 2 policies from higher education, 2 policies from labor and employment, 2 policies from driver's licenses and identification, and 3 policies from immigration enforcement. Policies were included for all 50 states from 2009 through 2019. Each year can be used for analyses for outcomes within that year, and you can use multiple years for changes over time and looking at these outcomes longitudinally, which remains sort of a gap in this space when we're considering structural environments and outcomes. In general, the US has an exclusive and xenophobic policy environment at the state level. So we looked at like over 10 years of these policies. It's over 780 policies that we coded. The takeaway is that it's largely exclusionary over time. But that's interesting for people because we've had federal administration changes, and yet you think that there'd be particular state level responses. For example, states would go more inclusionary as opposed to exclusionary in response to federal exclusionary policy, but we observe that that's not necessarily the case. Generally, over time, 2/3 of immigration policies adopted at the state level are exclusionary towards immigrants. The ratio of inclusive and exclusive policies narrows over time. In 2009, 32% of policies are inclusive to 68% exclusive. So what I mean by that is the gray bars or the darker bars are the exclusionary policies, so policies that are deemed to be discriminatory, and the blue is inclusionary policies, so where states took an effort to be inclusive of immigrants. I want to give an example from 2019. So you can see here, the blue colored states are the inclusionary states, and the darker gray or the black states are the exclusionary, and then the sort of light gray are the neutral ones. And the 4 most inclusive states in 2019, California, Oregon, Washington, and New York, had between 7 to 10 inclusive policies in place with about 0 or 1 exclusionary policies. The 4 most exclusive states, so Alabama, Georgia, Indiana, and Idaho, had 8 to 10 exclusive policies in place with no inclusive policies. And so how can this be leveraged in research? So this index is available for anybody to request from my website, and lots of folks are using it in various ways in health disparities and health equity research. I am using it in my own work to look at things related to pregnancy and birth outcomes. And so here's some results for inadequate prenatal care, which overall suggests that individuals living in an exclusionary state are less likely to have inadequate care than those in an inclusionary state. But we see the risk of inadequate care is higher for foreign-born versus US-born individuals in exclusionary states. Or to kind of put this in a simpler way, the effect of living in an exclusionary state on the risk of having inadequate prenatal care matters for foreign-born individuals. So we have all these theories about how to create structural measures and taking from policies or taking from court cases and creating things like the IPC index, which is a very useful tool, right? But what happens when you speak to immigrant women in this case is that what emerges for them and how they experience structural oppression or structural racism and sexism is definitely an intersectional framework that reflects their lived experience. And so this conceptual framework is something that's emerged from some qualitative work that I did with about 50 immigrant women and 20 immigrant serving community-based organizations in New York City. And for them, things like anti-immigrant sociopolitical climate and gendered power and resource inequality is not, those things are not separate. They operate simultaneously. They impact their lives in a concurrent way. And so I've attempted to capture sort of what emerged from those interviews in this conceptual framing that really merges and centers this intersectional approach for immigrant women. I would be remiss if I didn't mention some implications of Roe being overturned. And this is some work that we did early on last summer that really looked at, how does something like the overturning of Roe map onto existing measures of structural racism at the state level. And so a lot of times we think of something that's very gendered and in the reproductive space, like the overturning of Roe, as separate from something like structural racism. But our sisters and warriors in reproductive justice would tell you that this is the opposite. So these things are quite interrelated, and these things are quite connected. And so if you look at every single measure of structural racism, it maps on really quite nicely onto the states that were likely to ban or overturn Roe as of June 2022. Now we can update this with what's happened at the state level since then, but I think it's like really striking that we saw a lot of similarity across those states and environments. And so that raises questions for those of us who do structural work about really being intentional about what you're measuring, not overlooking certain dimensions, and thinking thoroughly about how these things are intersectional and related. I mentioned I would talk a little bit about global work and a global perspective, and so I want to touch on that here now. In the last 10 years in the US, there's been this proliferation of this focus on the structural environment. How do we measure it? How do we leverage it in our models? How do we think about it? And it's only been in the last 10 years. So you hear a lot about structural racism now, but the research in this space has really expanded in the last 10 years. I would say in the global space, we don't talk about structural isms, and we don't use the same type of language in the same way. Obviously, gender equality and global health is hugely important. It's a huge space. Gender shapes opportunities and risks, just like it does in the US in a global setting. Women and girls are vulnerable to health inequities with poorer access to healthcare and higher rates of mortality. Men and boys are also affected with higher rates of violence, substance abuse, and mental health issues. A sustainable development goal includes achieving gender equality and empowering all women and girls. As you can see, if we're thinking about this from the policy lens that we've been discussing for the US, we can think about the fact that things like it would take another 40 years for women and men to be represented equally in national political leadership, or the fact that only 57% of women are making their own decisions about sex and reproductive health care. But in the global space, we often talk about the solution to these gender inequities as women's empowerment. And there's a ton of research. We don't talk about structural sexism or the sort of structural barriers. We talk about this sort of catch-all, like we need to empower women, empower communities to empower women. And this is a framework by the Gates Foundation. It's the current sort of leading framework of women's empowerment that's leveraged around the world. I know this because I recently did a review of all the frameworks of women's empowerment, so I can definitively tell you that this one is the latest. But it's interesting because if you look at all of them, there's still, that structural oppression language has not been sort of integrated in the way that we think about women's empowerment in a global setting. And so I think there's something to unpack there and think about sort of what do we want to take from the sort of structural isms world of research to the global stage, like what makes sense, like do these types of measures like my immigration policy climate index, does that make sense at a country level? What are the other sort of barriers to doing work like this in a global setting? I think that some of the socio-political factors that, create gendered health disparities all around the world include, unequal gender power relationships, structural and social norms that really decrease education and employment opportunities, an exclusive focus on women's reproductive roles. Women are so much more than their reproductive roles, and potential or actual experiences of physical, sexual, and emotional violence. I mean, violence is a chronic global condition that women have to experience. And with that, I just want to acknowledge my funders and all my mentors, collaborators, communities, participants, everybody who makes all of this possible. And I'm happy to take questions. Yeah.
Wonderful presentation. Thank you so much. I'm a maternal and child's health researcher in the Latina population. So this was very helpful for me. I was wondering for the immigration index that you put together, have you looked to see for US born women who have like an immigrant heritage, how those exclusionary policies have affected their birth outcomes?
So this is a great question and a data limitation. So going back to John's point about we don't know what we don't collect. So it's really hard to get at second generation immigrants, which is who you're talking about. So those born to foreign born parents, so US born immigrants, because for example, in the birth records or the natality data, which is what I use a lot of times, I can get mothers country of origin, but I can't figure out if I can't get the US born equivalent. Yeah. So you can't identify them in a lot of data sources. And then a lot of, you can do in some survey research, but it's not, you can't make the same conclusions regarding birth outcomes.
Okay, thank you.
It's a huge gap though in the research.
Well, I'll have a general question then to kind of piggyback on what you mentioned and what John mentioned in terms of, guidance for data collection. So, and this was also brought up yesterday about, old data, if you will, and not being able to retrieve, a lot of information because it just wasn't collected. So moving forward, for if you're going to say like 10, 20 years from now, what should we collect? And will it be kind of like what John kind of hinted to, a epidemiologist nightmare if you have open boxes and, check all that apply and blah, blah, blah. But is that what is needed? Like what should, data collection look like for people? And what was Kat saying too about being multidisciplinary research and multi-level and that sort of thing to be a part of our solution. This would have to be something that the biologists could potentially do as well as, someone else in the field. So I'd like to hear everybody's thoughts on that.
Yeah. Should I sit or keep standing? Okay, I'll keep standing. I have a lot of thoughts on this. I'll try to be brief. So a large portion of my research focuses on Muslim and Middle Eastern origin communities. And as many of you are probably familiar with, there's been several months, well, now it's been decades long discussion about collecting race and ethnicity data that includes Middle Eastern communities, because in my eyes, they experience structural racism, oppression, and then they're not captured in data. So they experience this double burden. Similar to what John was saying, we don't know what we don't measure. And so without getting to the OMBs really thinking about revising those race categories, they had several town halls about it to include not just a Middle Eastern and North African origin category, but to also, combine race and ethnicity so that majority of the Latino Hispanic identifying population does not fall into other race, which has been a problem across the census for several decades now. So in the race ethnicity space, I'm a big proponent of collecting data on Middle Eastern origin communities because it would enable me to answer many research questions that I don't have access to right now because of data limitations, because these populations are invisible. In the immigration space, to touch on the question from the audience too, we don't have a lot of times when we study immigrant communities, particularly in survey research or large data registries, we do ask if you're foreign born or native born sometimes, but that's sort of where it stops. So is your parent foreign born or native born gives us access to a whole other next level of information, which is the children of immigrant parents, which is the second generation, which is when you start seeing disparities between US born and foreign born, that's naturally your next question is what is the status of children born to foreign born parents? And so I think we can create a lot of movement in the race ethnicity space and the racial equity space by collecting more detailed and reflective race and ethnicity data. And I think that we can create a lot of movement in the immigration research space by collecting more detailed immigration related data about the children to immigrant parents.
Could you use a microphone, please? Good. Closer. Thank you.
So I know somebody asked about immigrant population or even transgender. Do you think people will self-identify if they believe they're going to be discriminated against? Because that is what is happening. A lot of immigrant population, and I'm speaking from experience, have hidden themselves because they don't want to be discriminated. I know I have an accent and I am proud of it, but some people who identify with my immigration I themselves behind a different accent. So they might not self-identify because they feel that discrimination will follow.
Yeah, I think it's definitely an issue. I mean, in the Middle Eastern community, for example, I would say it's fairly divided on people who want to be able to identify and disclose that they're from the Middle East and people who do not for fear of retribution. We saw a lot of this with the proposal in the 2020 census to add the citizenship question and then take it away. We saw less participation from our communities that we would think are, largely immigrant in origin, and because people feel fearful of disclosing in a way that has detrimental effects for their lives. But I do think that with data collection efforts, there need to be community engaged efforts about why this is important. How is your data going to be used? Who's using your data? Data security issues. Like if we don't work hand in hand with the people who we're collecting data on and have people on the ground in those communities as liaisons for those efforts, then you're collecting bad data. Like it's not going to work. So my answer is yes, I think we need the data. Yes, there's going to be a lot of hesitation, but it involves sort of a proactive, community engaged and led approach in order to collect that data effectively and get closer to sort of what the actual counts are.
Thank you so much. My question was related to that, being from Texas, a state where there is a lot of this kind of new policy or old policy that around immigration, we struggle on whether to ask about that, especially if any of our projects are state funded for fear of exactly what you were just mentioning. So I didn't know if you had any advice on that, or, I mean, I think what you just said is very useful. But
I think we know how to do it correctly, right? We know that we have to have people in the communities. We know that we have to have trust with these communities before we go to be extractive for research purposes or whatever purposes. And I think despite the fact that we know all those things, we know how to do community-based participatory research, we know how to do community engaged research, and those are different things and different degrees of community involvement, but we don't do it. So that's the reality, is we know how to do this right to get the right information. And sometimes during the pandemic time, things are moving so fast, it's hard to do anything in the right steps that we know to take. But I think it's a lesson that you have to build the trust with those communities now. You're setting yourself up for the future. It's important to sort of build those relationships early on for something that you might want in 10 years, or, if there's another sort of global catastrophe, that those relationships are sort of built and in place to for communities to be willing to share their data and provide that information. So there's a lot of health education and health communication that has to happen around data and surveillance.
Hi, thank you for your presentation. I wanted to ask, in your IPC index that you created, did you include the EMTALA Act, or you included only the policies which existed between 2009 to 2019?
So it's 14 policies at each state level. And we were really intentional in including when the policy was passed or a decision was made to include the policy. We didn't include that specific policy you
Yeah, it's
mentioned.
Emergency Medical Treatment and Labor Act.
No, we didn't include that specific policy, but we're also really mindful, and this is a longer discussion about including when a policy was passed, because something like the Muslim ban, the date that it was enacted led to a lot of protests. It sort of created the social shock. The implementation of it and the Supreme Court upholding it took another year and a half. And so I think policy enactment in the structural measures space gets into something that's a little bit more tricky and has to be thought out a little bit more, like what is the impact of enactment? This is not your question. I'm going on a tangent, but the answer to your question is no, we didn't include that act. But I think thinking that act reminds me that thinking about the difference between passage of a policy versus policy implementation is really important in the structural measures space.
Thank you.
Yeah, I just wanted to circle back on Joyanne's question. I don't know if this mic is on. Oh, yeah, there you go. In terms of the gymnastics we have to do to capture this data, and I think the onus is on us, right, as epidemiologists to do the gymnastics, right? Otherwise, we can't make the changes. And so I'd say, yes, we have to collect it all, and we just have to be willing to get really flexible in our gymnastics. And I also remembered Krieger's quote, if you don't know, if you don't ask, you don't know. If you don't know, you can't act. So I definitely wanted to give her justice in that. So.
Do you have any final words, John? Okay. So we're at time, but I did want to invite you all to continue the discussion. There will be tomorrow, there will be another plenary session. It's entitled Conducting Prevention Research and Teaching to Achieve Social Justice and Health Equity and Political. I can't even read. I know I need readers. It's a thank you. It's all I see is else. Politicized times, a critical dialogue. This will be tomorrow, June 2nd, from 10:45 a.m. to 12 p.m. All of our panelists here will be there, plus I believe the panelists from the other plenary sessions. So it'll be a great time to really get the intersectionality and all the good things and the latest and the greatest. So we hope to see you there. Thank you so much for joining us.